Nurse Theorists, Portraits of Excellence. In this edition, we feature Ida Orlando.
My mother and father are both from Italy, from provinces that are kind of next to each other, but they didn't meet there. They met here in the United States. The marriage was arranged, and some aunt or uncle picked out my father for my mother, and they married. She had no say in the matter. My mother was a homemaker and raised her children, and it was during the Depression, and so that's where I kind of learned how to keep house. My father was a drill press operator for the transit system in New York. My father was a nut for opera, and during the Depression, my mother told him that he could not buy his season ticket. And he didn't know what to do. Money was very, very scarce. And I'm sure for the season there it was next to nothing. Now one opera is $125. So he went and interviewed at the Met, and he got a job on stage as an extra hand. So he had the best seat in the house for the season. I have two older sisters, two older brothers, then I came, and then I have two younger sisters. So I'm in the middle of the girls, but fourth. I did not enjoy school. It was not a fun thing for me. It was like just, you had to hang out, you had to go to school. I just couldn't learn the rote stuff that they wanted us to learn in a rote way. And I found it very difficult. And my mother was not very supportive of my reaction to education. For example, the teacher would, if I asked a question, the teacher told me not to ask a question. So I'd ask a question anyway, and she'd ask me to go to the board and write 2,000 times. I will not ask questions when I'm told not to, and I told her that was kind of ridiculous. I'd rather do something constructive, like wash her blackboard or clean the erasers. And so then I refused to do it, so then my mother would have to come to school, and my mother would say, "Now you do what the teacher says," and I'd say, "Yeah, I'll do what the teacher says," but I didn't do it. So in that sense, I was not a good student. Like most people in those days, there were not many choices, and it never dawned on me that I'd want to be a teacher, so what else was there to do? When I told my mother I wanted to go to nursing school, she said, "No daughter is going to leave my house before she's married." So I got this couple to work on her, and they knew something about nursing, and they thought it would be good for Ida to do that. And I eventually, I cried day and night because she wouldn't let me leave the house. You know, you just didn't leave home until you were married. And then I think she found out that their curfew was earlier than hers, that I would be there 7 days a week, I would be accounted for, and eventually she let me go. I think it was an adventure to leave home and go to nursing school, although I did think that I had infinitely more freedom at home than was available in the school. I mean, the rigidities were unreal. You know, you had to wear hairnets and white shoes and white stockings. And the teachers there gave me some rationale for wearing the hairnet, because hair could get into a wound or contaminate something. I was never able to identify, you know, what was the relationship between providing care and white stockings. My cause is that if we are rational beings, we ought to act based on a rationale that we're aware of, not because somebody says so. If I obey the law, I obey it because there's a rationale to it. I don't obey it because the cop told me I had to. I went to work at a place called Shore Road Hospital. It was a place where most of the local women delivered their babies. And I didn't last very long because patients would come to the hospital and be ready to deliver, and doctors would say they wanted the mother to wait, or they weren't available, and babies got born in taxi cabs and things of that sort. When I left the obstetrical hospital, I found a job at another local hospital at home, It's called Maimonides Hospital, and I worked there on and off because I just decided to go to school and get my bachelor's. St. John's University is the school that I got my bachelor's degree from. One of the reasons why I went was because I couldn't stand what was happening in nursing. And everything was so rigid and so freedomless to help people. I thought if I went and studied public health, there'd be more freedom. I'd at least be outdoors and in people's houses. But I thought it turned out to be very much the same. The response was not to the patient, the response was to the protocols. I got a master's degree in mental health consultation from Columbia Teachers College and immediately went to work at Yale. I was so delighted when I got the job because I would have done it for free. I was so interested in seeing how we could change this nursing curriculum. It was a research project. Someone else made the application. They called it Integration of Mental Health Concepts in a Basic Nursing Curriculum. I met my husband, Bob, at Yale. He was working in the School of Public Health and the Department of Architecture as a research associate in architecture and public health. And he had an office directly over mine, and I thought we were going to date. But 2 years went by and we did not date. But one evening I was sitting in my office late and I was dictating. In those days we had secretaries and dictaphones and the rest of it. And Bob said he'd been looking for me for 2 years, looking for the moment that he could say hello. So he saw this light in the corridor coming from my office, and he walked down. He said, "Oh, you're working late tonight? You know how that goes." And I said yes, and suddenly I realized that I had to put the dictaphone down because he was about to turn away and leave, and I'd been waiting for 2 years. Anyway, I said, "Oh, I've worked long enough. Did you eat?" And then we went out to supper and married shortly after that. I think Bob is a wonderful man, very talented. He's a very bright guy.
I think the most telling thing I could say about Ida is it sounds like a terrible cliche, but what you see is what you get, both in her professional work and her personal life. Sort of honesty of feeling is the thing that comes across, and it's true. It's what she feels at the moment. I think this spontaneity is one of the most wonderful things about living with a person like Ida. You know how your conversation is affecting her, good, bad, or indifferent, and you always know where you stand. Living with Ida can be exciting. This is like someone living with owning a famous painting, Rembrandt or a Van Gogh or something like that. You realize that you have the care of a worldwide treasure on your hands. Not that she can't take care of herself, but I feel very protective about her. While we were just seeing each other, I got an offer I couldn't refuse from an architectural firm in Boston, and decided to move my life to Boston and decided we would get married, and did. Ida was on the point of leaving Yale at any rate. She retired briefly from nursing and began working at McLean about a year and a half later. She worked for about 12 years at McLean, then retired for a few years after we moved into our present house. Again, got fed up with it and decided that she had to get back to working in nursing, take care of patients, and has been here at Metropolitan State Hospital for about 8 years now.
Well, I first met her in January of 1963. I had heard that she was at McLean Hospital, which is where I went back as an instructor in nursing education. She has the true concept of what the function of the nurse is, which is not generally accepted because people don't understand it. The language is very simple. If you read it, it sounds like nothing. But if you really understand the implications of it, then you understand it's more or less of a global concept. But more than that, there is always a communication problem between nurses and patients, between nurses and nurses, between nurses and doctors, and so on. In addition to her very clear concept of the function of the nurse, she also taught us how to deal with our personal reactions that we had towards patients. We all had personal reactions, negative or positive, and didn't know what to do with them. She knew, she taught me, and I learned, and then I eventually began to teach other people. So she not only knew the function of the nurse, she knew how to help us to go about fulfilling it, and we could tell by the patient's behavior whether we had succeeded.
Ms. Orlando discussed her nursing process with Dr. Jacqueline Fawcett in the boardroom of the Metropolitan State Hospital.
Ida, I'd like to thank you so very much for agreeing to do this interview. I'm really interested in what you have to say today.
Well, I'm very happy to be here.
Ida, your first book, The Dynamic Nurse-Patient Relationship, was published in 1961. I noticed in the preface, though, that you finished the book when you were still at Yale in 1958. I wonder if you could tell us what motivated you to do the work and then to publish it as a book.
Well, of course, we were under obligation to produce a report of what this study was all about, the integration of mental health concepts in a basic nursing curriculum. And the person that had applied for the grant thought that it was just as well that we would produce the report in the form of a book. And so that's how that book came to be, except that no one would publish it as it was. And, I don't know, possibly 2 years or a year later, some new editor came in at Putnam, the firm that had turned it down for publication. And his name was Mr. Miller. And he decided that this was exactly what nurses needed because he had just left the wards at Bellevue. And he knew that these were the kinds of things that nurses were struggling with. And so the book got published. But I think it was 1961.
Could you tell us a little bit more about the work that culminated in the book?
Well, as I remember, I didn't know what I was supposed to do. So they established an advisory committee composed of a psychiatrist, a psychologist, a social worker, and you name it. And everybody was telling me to do something differently. And I let them talk, and I let them talk. But meanwhile, I was faithfully recording all of my observations on all of the units at the Grace New Haven Hospital. There were students in obstetrics, students in maternity, students in the clinic, nurses in all of those places. And I kept the records. I'd spend the whole day out observing, and I'd write the record. Well, then Ernestine Wiedenbach became interested in what I was doing, and so I did what I continued to do what I was doing, but a little more intensively with the maternal and newborn service. And when the study period was over, I just decided I was repeating similar records. They were very much alike. And I don't know, I had about 2,000 records, and I didn't know what to do with them. So the psychiatrist told me to analyze them according to concepts of hostility, anxiety, the psychologist according to something else, and you know the rest of that. Everybody had their own framework. So I sat down, and I just studied them, didn't know what to do with them. And nobody could tell me what to do so that it would make sense to me. So one day I decided, well, these are good records. This is good nursing. The baby was crying when the nurse was finished. The baby wasn't crying. These are bad records. The patient said he didn't want it, and 20 minutes later they tie him down, or they restrain him, or he's screaming, or he signs himself out of the hospital. So one represented good nursing and the other bad. So I made 2 piles, and I didn't know what to do with the piles. So I decided to mix them all up again, and I asked various people to group them. I asked students, I asked nurses, I asked professors, anybody that was willing to do it. And lo and behold, everybody piled them exactly the way I did. Everybody said, that's good and that's bad. And for once we found that there was some agreement in nursing. So I thought, well, if that's what made that decision, then what went into making good nursing had to be contained in the record that the judgment was made about. So I still didn't know what I was doing. And we just poured over it day and night, and I kept putting the material away because every time something, all the good nursing, had a good outcome, was a medical outcome. The fever was reduced, the diarrhea stopped, the bowel movement came, the urine flowed without a catheter, the patient expressed relief of pain. And I kept calling those things medical outcomes, and it took me several years to realize that they were not. So I kept studying these records, and I thought, well, what did the nurse say? The nurse stated something that could be categorized as a perception, or the nurse stated something that one could characterize as a thought, categorize, excuse me. And that's the way I developed the process discipline.
Your second book, published in 1972, dealt with a study that was done at McLean Hospital. I wonder if you could tell us about that work.
The second work was the result of a second research project. When I first went to McLean Hospital, they had the similar problems. Patients would be dragged to occupational therapy, for example. And nurses did not attend to the individual at a given moment in time. So again, I did sort of the same thing. I went throughout the hospital and I observed nurses working and what happened to patients, what they did, what they said, and I prepared a very thick report and told the director of the hospital that we needed a training program. And he funded it. The only difference there is I got the nurse off duty for 6 weeks at a crack so that one could do something instead of a half hour, maybe every other week. And the training program got going, and the director of nursing that was there at the time retired, and they hired a former student of mine, Hilda Mertz from Yale. She became the director of nursing, and we decided that since all this work was done, now we ought to test it, see if what we were teaching was effective, and the nurse that learned it, if she was more effective in her dealings with patients. And that was the application that we made out. We wanted to test the process discipline in an experimental and in the control group. And so those findings got published in that second book. It really tried to quantify what the first book was about. I think the first book was looking at quality, and the second one tried to quantify it so that people would say, it does make a difference.
And did it make a difference?
Oh, I think it did. And I didn't do the statistics, the statisticians did. And I didn't do the methods, they did. And what we isolated as the discipline variable was statistically significant, 0.001, to the production of outcomes. We isolated other variables, like if you just asked the patient a question, that was a variable. If you just made a statement, that was another one. And then when you did it according to the requirements of the process discipline, then that did relate to outcome.
What is the current work that's being done with the process discipline, with the theory of nursing process?
I don't know what's being done elsewhere, and I do know there are people I know as individuals here and there that attempt to integrate it in whatever work they're doing, but there's no gung-ho effort in any one place. Most recently, a lady by the name of Linda White at the Veterans Hospital in Livermore, California, is making an application for a grant where she would like to replicate at least pieces of the research that was reported in the 1972 publication.
I'm interested in the impact of the process discipline of the theory of nursing process on how nurses think. How does the use of the process discipline influence what or how nurses think about nursing?
I would like to rephrase your question and see if you still would like me to answer it. It doesn't influence the way they think. It gives them, and it enables them to acknowledge that they do think as individuals. And what I try to do is get them to use those thoughts with discipline so that patients benefit from it. I don't think I influence thinking, except that they start to think, gee, I had an idea and I didn't even know it. So they're influenced, but I don't think it influences their thinking.
Could you give us an example?
It happened the other day. Patient glared at a nurse and said, "Get out of here." And she said, well, I would back away and say, "Is this better?" And that would be the end of it. She would permit the patient to interpret her behavior in any way he felt like doing it. So I said to her, "Why did you back away?" And she said, "I want the patient to know that I am taking what he says seriously." So I said, "Why didn't you tell him?" She said, "I never thought of that." So it's only a matter of capturing the immediate reaction and giving it verbal expression, and then, eliciting from the patient's reaction to what you did.
Inasmuch as you've said that the use of the process discipline does not influence how nurses think about nursing, I wonder, does it influence or change or somehow modify what nurses do as nurses?
I think that's precisely what it does do. It at least trains or teaches the nurse that what she does think must be used. It's all she really has. That she must give her thoughts verbal expression. In giving them verbal expression and then asking the patient whether her thinking is correct or not correct from the patient's point of view, she elicits additional data so that what she does eventually decide to do is more in tune with what the patient's need for help is. So the whole thing is geared to influencing what she does. Then in turn, if she's able to accomplish an outcome, it does influence her thinking in the sense that she puts more value on her individuality as a thinking person.
Do you think then, Ida, that the use of the process discipline is the essence of nursing? What makes a nurse a nurse?
I think so. Earlier when we were discussing my observations at Yale, I left out, I believe, the most critical part of the story. I sat over these records and isolated what the ingredients were in the good nursing as compared to the bad nursing. And I found that if the nurse stated a perception, thought, or feeling and asked a question about the same perception, thought, or feeling, the nurse produced the good nursing. If she did not do that, she produced the bad nursing. And just to illustrate how individualistic it was, I produced a lot of good ones and I produced as many bad ones. And other nurses that we would call, she's not a very good nurse, produce good ones and bad ones. So that in that sense, it isn't that if you use the process discipline, you're a nurse. You're a nurse if you have a registered, if you're licensed, but you don't get your outcomes unless you use it. And it happens so frequently. I laugh here because people say, but Ida wasn't there and she knows the scenario. Well, I know it because you told me what you did. It isn't that it makes a nurse as much as the nursing is not effective or beneficial to the patient.
You have mentioned that the use of the process discipline is appropriate with any patient, regardless of situation or medical diagnosis. So it would seem then that the scope of the theory is very broad.
I think so. At least I had no experience in psych nursing when I was teaching the psych program at Yale, and I walked in cold, and we did it. So that it was applicable. It doesn't matter what the condition of the patient is. I question whether nurses that simply monitor machines are doing nursing. I mean, I question that. So it certainly wouldn't work there. I couldn't tell the machine I had a thought and I couldn't nurse a machine. But in terms of what the patient's going through at a given moment, in any setting, I say it's applicable. And I think the literature shows that to some extent.
Ida, what are you doing now in terms of your own work?
Nothing very much, except that I am supervising nurses in the hospital at the current time, and we're having a lot of fun when the nurse is available. But no matter how we schedule things, there's always an emergency. We are understaffed. We can't seem to get enough nurses. And so I'll try to help them on the ward. Maybe they'll get done 20 minutes earlier and we'll have some time to sit down so she can learn something more about solving some of the problems on her unit.
Ida, what are your plans for the future?
What are my plans for the future? Retirement is so close. I don't know. We may get involved in another research project here, but nothing's quite decided yet.
Ida, if you were to summarize your career, what would you say has given you the most satisfaction?
I don't think there's any isolated event. I think in a personal sense, when the course of an individual's life changes because of the help they've received, I think that's really what I've gotten out of it. I mean, I felt pretty good when I did the second book, but that was 1972, and somebody wrote a book about me, and they didn't even know I wrote the second book, and they published the book in 79. So I think while I personally feel gratification from it, I think the really important thing is when a nurse says, boy, I know what I'm doing and I can do it, or when I see an outcome in a patient.
Ida, what do you think is your most important or most significant contribution to nursing?
Well, my late friend Anna Dugan told me 30 years ago that I wrote the definitive work in nursing, but it's hard to believe these days anyway.
I believe it.
That's very nice of you to say that. But mind you, I didn't write it. I didn't make it up. I found it from nurses that did it good and nurses that did it bad. I don't think I made it up.
You discovered what was there.
That's right. I think that's it's putting it together in terms of what was there. That was so hard for so many people to articulate. Well, I couldn't do it either. I couldn't find anybody that could. But I knew there was something. The good nurse walked in and made a bad outcome, or the bad nurse walked in and made a good outcome, and vice versa. Well, something had to have happened that made it happen.
Ida, I'd like to thank you so very much for this interview. It's been interesting, informative, and I've really enjoyed our conversation.
I thank you too, Jackie. This has been a wonderful opportunity for me. Thank you.
met Ida about 2 years ago. She is an energetic, vibrant woman, brilliant, but very, very simple. I mean, she's just an unusual person, a very easy person to work with, because she's so honest, so just herself. And her work is so much a part of her that it just comes out that way. She gives you all her attention. And with patients, well, I'd like to just mention last week a patient that I'm working with, a very difficult patient who's been on what we call one-to-one supervision for 5 years now. The patient is very regressed, extremely ill. She's been in the state hospital system since she was 18 years old. She talks in words that don't make sense to us anyhow. One of the other staff members said, "What's my name and what's your name?" And she said, like, apples, oranges. And she looked at me and she said, "Honest." And when she said that, I knew that she recognized what I was doing. What I was doing is really using what Ida has taught me. And that was the name she gave me. I thought, she's naming Ida. So Ida's very honest with whomever she's with.
She taught students how to meticulously observe behavior, how to begin to understand what the nurse was as a vehicle in that whole process of observer, interpreter, and to verify it with the patient. Is this what you really mean to say? Is this what you're really trying to say to me? Is this really how you're behaving? And then let the patient say, yes, indeed, that's what I've been trying to say all along. So it's that kind of very simple interaction that she just sort of stressed home, and I think it's made some of us practice nursing a little differently.
I have been a colleague of Ida throughout the past 20 years. The perception that people would have of Ida through me is that Ida focuses on the patient and the patient only. The patient is a central core of her theory, like probably no other nursing theory. Her organizing principle, which is to find out and meet the patient's immediate needs for help, is something that is so simple and so elegant, and yet it is so frequently misunderstood in nursing. I think that Ida does give people a way of understanding nursing, and as a result of that, they feel better about being a nurse. In fact, I feel that nursing is the greatest profession, and I attribute a great deal of that to Ida.